I welcome all of you who are in today's session. I am Hafsa Ijaz, who is a student of MPhil Pharmacology from Government College University, Faisalabad. I welcome all of you here, especially our respectable guest of today's session, guest speaker, as well as the panelists of today's session, and the students of the universities from Shifa Tamil Millard University, University of Lahore, Dow University of Health Sciences, University of Veterinary and Animal Sciences, Cancer Care Hospital and Research Center Foundation, Abesan University Peshawar, Local University India, University of Sargodha, University of Rajasthan, and Government College University, Faisalabad. I'm introducing this session under the umbrella of Croí Innovators. Croí Innovators is a research group, and in this group, we are working and providing services in multiple domains of pharmacy. And one of them is Cardiometabolic Disorders Research Group. This group is doing clinical trials these days, and that's why we requested our guest speaker Dr. Syed Wasif Gillani, to share his latest knowledge in this profession with us. First of all, I would like to request Director of today's session, Dr. Malik Hassan Mahmood, who is Associate Professor of Pharmacology, Government College University, Faisalabad. Sir, please join the session. Formally welcome our guest speaker and introduce our respectable panelists. Over to you, Sir Hassan.
Yeah, thank you, Hafsa, for organizing and for making all together for this very nice session. I first of all like to thank our guest speaker, Dr. Syed Wasif Gillani. So thank you, Dr. Gillani, for taking it out.
Okay, I guess Sir Hassan is facing some connectivity issues, so I'm going to introduce the panelists. Dr. Uzma, who is the chairperson of Pharmacology Department, Government College University, Faisalabad, Assistant Professor, Government College University, Faisalabad, Dr. Liaquat Hussain, Dr. Ammara, who is the Assistant Professor of Government College University, Faisalabad, and Dr. Shumaila here, as well as Dr. Abdul Malik from University of Sargodha. Thank you so much, everyone, for your presence today. We designed this session specially for our scholars who are trying to gain knowledge in the practice of clinical trials. Now, I would like to request Dr. Syed Wasif Gillani to formally start this session. Over to you, sir.
Thank you very much, Hafsa, for the introduction, and thank you very much for all the people who spared their time for this session. Hafsa, before I start, can you please make me a host so I can share my screen?
Okay, sure.
Much. It's very nice to see all of you around here, and it gives me a great pleasure to talk with my fellow students from Pakistan. Today, I'm going to talk a few things about it. Indeed, clinical trials and clinical research is a very vast topic. Unfortunately, I cannot cover everything in this short time. There are much to say, and there are many more trainings required to make someone as an effective researcher. So I'm going to overthrow with certain basic things, the important things that I believe is important for you to start up in your career and to develop something that can be effective enough. So today contents, I'm going to go through with the clinical trial terms. We will talk about certain definitions and the procedures for planning and monitoring. I will show you a clinical trial registry, and as well as the other types of registry where you're required to go through with the approval and registry of the trial. There are different types of trials, so I'm going to give you a quick brief of what types of trials we are dealing with in a clinical research. I'm going to tell you after that some necessary parameters for the research. More prominently, clinical research and will be not more focused on clinical alone, but the the uh, the clinical parts are usually same in trials and other prospective studies. Study variables, it is a very key element. I'm going to talk about it. Biases to consider. This is the major part that I want to share with you. Mainly, a lot of researchers that I come across in different times of my career, they were not aware about these biases, and eventually their study, their efforts got ruined in the end. So we will talk about them, and then we will see how we can reduce the biasness in the actual setting. Then we will talk about development of clinical trial units. So if you need to develop your clinical trial units, what are the protocols? What are the infrastructure requirement? What are the support teams you required? And how you can proceed with it. So let me start with the clinical terms, definition, and procedures. As we all know that in medical and clinical research, there are so many different ways, there are different methodologies, and I'm sure that all of you have studied those things in your curriculum. So most probably you will be familiar with the basic research, that is a laboratory-based research normally done in the labs with pharmaceutics, with pharmacology, in vivo, in vitro studies, dosage designs, and all that. We have clinical research as well. We have healthcare services research system as well, policy research, and educational research. So these are the basic familiar terms. There are many clinical research findings. The problem is those findings will become invalid or less meaningful when you have certain biasness or ignorances during the process. I'm going to highlight few of them here, and then in the upcoming slides, you will see there are few things that you really need to be very careful when you conduct your research. So if you ignore about the presence of literature, previous similar studies, the paucity of similar studies in different regions, poor study design or implementation, monitoring, planning, it involves both monitoring and planning, low test agent efficacy, no predetermined statistical analysis techniques. So you are not well aware about the statistical techniques or methods you are going to use to evaluate your objectives, aims, and research questions. Inefficient reporting, bias, and conflict of interest. So there are few things in inefficient reporting, and inefficient reporting also requires an extensive training to your research team members, because multiple people will cause we cause this another form of error, that multiple human errors. The way of collecting data and reporting data will be different from one person to another person. So there must be a standardized training among the team or the members of the team to have the similar level of understanding and data collection capacity, or even reporting capacity. Unfortunately, in our current healthcare system, we have so many unethical and moral tendencies. We know that there are several academicians, we know that there are several teachers who enforce young students or immature researchers to do the research for the sake of publications, to get promotions and this and that. And this leads to a bigger problem, because there is no proper training, there is no proper guidance to these students, to these young researchers, that how to conduct a research. And the problem is that when they learn by themselves or they learn from the other people, there is a highly likely chance that they will learn something wrong. And when they learn something wrong, it will become into their practice. So in future, whatever they do in the similar wrong manner. So we need to be very careful when we deal with our students or young researchers. We need to encourage them, we need to train them, we need to give them a guidance. This will lead to a successful projects and a successful publication. Next step, So there are concerns in clinical studies. As we already know, there are epidemiological studies is a part of clinical studies and medical studies. And in this field of epidemiological studies, what we do, we look into the effect of determinant on the outcome. So meaning to say that if I am going to expose somebody with a factor, with any exposure, with any variable, what would be the outcome in terms of clinical outcomes? Maybe you can put outcome as a death and a life. So if I put someone on a, I will expose someone to the COVID variant, specific variant, what would be the outcome? The patient are alive or dead? So this will normally be evaluated by epidemiological studies. The problem is when we do any study, there are several measurement errors. Measurement errors usually give rise to biasness, and this biasness leads to invalid results. So even you conduct your whole study, you did everything, you did statistical analysis, even your conclusion, you make a conclusion, but if you have certain measurement errors or imprecise reporting of effect or different types of errors, if your study exposed to that errors, all your analysis and conclusion become null and void. We cannot rely on your results. Okay, so precision is very important when you deal with your research. And normally in clinical research, we say that the precision will increase when you have increased sample size. Okay, so this will avoid several level of biasness, or we avoid several biases by increasing the sample size. But there are still several things that are independent to the sample size. They are more of the nature of your study design. Okay, and I will tell you that what are those biasness. I want to highlight one of the biasness here is the Hawthorne's effect. Hawthorne's effect is an effect when a patient know that a physician or a clinical pharmacist is looking at them or monitoring them, then the patient will come and behave at their best behavior. So for example, if you have a diabetic patient and tomorrow he knows that you are going to check his blood sugar, so what he's going to do today, whole day, he will do a fasting. So tomorrow when he will come to you and you will check their blood sugar level or blood glucose levels, it will become normal. After the test, he will come back home and now he start having his unhealthy and the full carbohydrate diet again back. So this called as Hawthorne's effect. Hawthorne's effect is determined to the patient characteristics. There are ways to avoid Hawthorne's effect, but it is more probably related to the study design. So if we correct the study design, we can actually correct this Hawthorne's effect. Now, next thing, as we know, I want to mention here this hierarchy of evidence. I believe that you guys are familiar with this hierarchy of evidence. In clinical studies, we use this hierarchy of evidence. So more you go towards the top, the level of evidence is increased, meaning the decision or the conclusions you make in your research are more valid and reliable. Okay. Now, as you see on the top is the systematic review and meta-analysis. This is not what we are going to discuss today. We are going to discuss randomized controlled trials. But meta-analysis and systematic reviews is a project when you compare the findings of several clinical trials or prospective studies. You gather the data from that several studies, and then you conclude one thing, that either the treatment favors the outcome or the treatment not favors the outcome or the placebo favors the outcome. Okay. Now, the second thing is the novelty of research topic is less important than the clinical applicability of the topic. It's very common with me when I'm giving research topics or when I'm discussing the research projects with my students. I often tell them, and majority of my students usually when they came, they asked me one thing. They asked me, sir, tell us how we are going to do over research. And they are very much interested into a study. That study has a lot of uh, patient related data, or they were talking about something novel, that I want to do something that nobody have done before, and something like that. And I tell them always that please understand the concept. Please understand the concept of novelty and applicability of the topic. uh, it is good to have a novel research project. It is not bad. It is good. But in a clinical research, what matters is the research you are doing is or has a clinical applicability in the society. So if you are doing a research, in the end, is your conclusion is giving something meaningful to the surgeons, physicians, or the clinical pharmacists to apply in the practice or not. Otherwise, if you look around the internet, you will find several studies with several articles that has a very novel idea. They have very good, the results and conclusion. Unfortunately, they are not clinically applicable. Why? Because they might be designed for a very specific center, very specific control environment, and they cannot be generalized even to the community or to the general population. Now, researchers, uh, they required, so I normally tell my students from the beginning that the researchers, they require writing and reporting skills from the beginning. And this will persistently, I tell them to please go through with their skills. And I tell them that please look into the articles. More you get experience, more you will be more effective in writing the stuff. So when you talk about clinical research has several parameters that you can look into it. There are several parameters that includes diagnostic research, prognostic research, interventional research, etiological research. Please pardon me because it looks like that the counter has started now. So what I'm trying to say here is there are prognostic research, and I'm putting here some examples. So when you are deciding to do your clinical research, please look into the method you want to adopt. You want to do a diagnostic research where you will be more focused on the diagnosis of certain diseases and determine the pre risk factors. So if you control those pre risk factors from the beginning, you might control the factors or you might control the development of the disease. Again, prognostic factors, interventions, etiological studies. The concern here is that your research question, your research aim, and your theoretical design. These are the three elements that you need to be very careful when you design the project. Your research questions should clearly be answered or should clearly be reflected in your aim. And your aim of the study should be properly addressed by using your specific research methodology or design. Now, when we talk about confounding variables, I know that when we do our study, there are several variables, and we talk about those variables from the beginning. Confounding variables are those variables who are actually causing confusion in the true effect. So if I am saying that I give this risk factor to these patients and this will cause patient death, so am I 100% sure that this factor is a cause effect model, or there are other factors who are also causing the death in the same patients? So confounding variables are very indigenous as well as extraneous factors. Indigenous factors in terms of analysis, exogenous factors in terms of your method design, your patient characteristics. So we need to be very careful identifying confounding variables at the time of proposal development. Okay, when you develop your proposal, be very careful. Identify from the beginning. So you being very careful during data collection and reporting process. Now, there are different designs, research designs. I'm putting here some examples in front of your research designs that if you are doing a cross-sectional studies, cross-sectional studies is actually a snapshot of the population. There are no multiple follow-ups. There is only one time, one single snapshot of the condition, of the disease, of the outcome. No multiple follow-ups. There are no change in time. There is no time and effect model. There is no risk exposure and factorial analysis. There is no predictive analysis. Okay. However, if you look into clinical trials or nested control trials, these are the trials where we are mainly focused on the prospective studies, and we will continuously monitor patients with certain set of instructions. Certain set of variables are monitored over time, again and again, to see the effect over the duration and to see that the exposures or the factors you are giving or you are exposing to your patients, what are their impact, short-term impact and the long-term impact on the clinical outcomes. We need to be very careful when we are designing or when we are deciding what research design we have to apply, because that will require further explanations that how you will select the patients, what the structured data collections, at what stage you will do that, and how you will do that. Experimental and non-experimental research designs. There are certain advantages of experimental and non-experimental designs, and there are disadvantages. So I'm going to highlight some of the advantages and disadvantages here. Non-experimental designs like observational studies, surveys, the results are very quick. Majority of the people, if you look around you, they are doing surveys and they will immediately publish. They got the results very fast. They are relatively less costly. Their insurances are not involved. Patient cost is not involved. Material cost is not involved. No recall biasness. So you're not asking patient anything to remember until unless your method is ask them to remember something. No time effect. So it's a snapshot. We are not looking into at 0 months and then 3 months and then 6 months and then 9 months and then 12 months. We are not looking into time effect. Plus, it is a real life data. So we are not manipulating the situation with case and controls. We are not restricting the boundary environment, or we are not constructing the environment. It's a real life data. It might be favors your outcome. It might not favors your outcome or your objective, but it is a real life data. In contrast, experimental studies, we are comparing different groups. And as I told you before, Hawthorne's and placebo effect mitigating the outcome. Straightforward, robust statistical analysis, convincing results as an evidence. So majority of meta-analysis, if you see, they prefer to have experimental design of study for the development of evidence or synthesis of evidence. Disadvantages: observed non-experimental studies, they are observed, unobserved, and residual confounding. There are several ways that several factors that you might miss during the analysis part or during the data collection or repeating phase, or due to several factors are there. Now, expensive experimental studies, they are expensive, they are time consuming. They are overly controlled environment that will somehow affect the outcome of our results. There are several times that when I do my clinical trials, there are several times that I have dropout patients in the middle of the trial, because we cannot force anyone. It's a voluntary project, so I cannot force anyone to complete the trial. So there are several dropouts. So we can adjust that by anticipating this problem in the beginning. So in the beginning, I will have 25 to 30% increase in sample size, because I am anticipating 25 to 30% dropouts during the period of 6 months. If your study duration is more than 6 months, then most probably your dropout is what I can say, your dropout probably around 40 to 50% dropout. Next, okay, so time frame. So I'm very much emphasizing on time frame, because when you talk about clinical trials, you talk about prospective studies, or you talk about anything relative to the clinical study in which you are looking into the effect or the risk factor and exposure to the effect on outcome. So this is cause and effect model. When you are looking into cause and effect model, you need to make sure that your time frame is very much uh, decided at the proposal level, that what you need to do and how you need to do. So remember that there are different time frames and different research designs required different time frames. Okay, so there is a time when we expose the patients to risk factors. Now at this time the patient is not manifesting any pathological disorder. At this moment patients are only exposed, and now the body is start changing little bit of the what you can say the pre-clinical or sub-induction. We have several issues with retrospective data, and we mainly use retrospective data just to generate rationale for any experimental design or to identify any adverse event or any effect that will help us to design a prospective study and solve that problem. Uh, now, now there is a different manifestation. So I want to explain you one more thing here. That remember, there is a movement or there is a research design when you will do evaluation from the sign and symptom. This patient already developed sign and symptom, and from this movement to do the clinical outcome. Now this is called survival analysis. Okay, survival or fatality analysis. This analysis is very important analysis in clinical research, where we will look into a certain disease and we look into the impact of that disease on the overall survival of a patient. Okay, there are several models you can apply for survival analysis. It helps us to optimize our care. It helps us to optimize the pharmacoeconomic aspect of the hospital. It helps us in several ways. Okay. Now, as I was telling you that in clinical research, among clinical research or among clinical trials, there are different types of trials. So if you look into those clinical trials, you will better understand that there are several methods that you can apply, and these methods are different from each other based on the methodology, based on the objective of your study. So if you look into the simple clinical trial, that simple clinical trial is normally a randomized controlled trial where there is a randomization of the process. Open labeled clinical trials are those clinical trials in which the patient already know what I am taking. So there is a problem in this trial, because when you put open label, then some patients say that some patients know that they are taking placebo, and definitely there will be no impact. They know that they are taking placebo, and some patients, they start complaining, why you are giving me placebo when I have an active disease right now. So there are some ethical dilemma. We will talk about those dilemmas later on. Single blinded clinical trials. This is a blinded clinical trial when the patient don't know what they are taking, but the prescriber know that which patient is taking active drug and which patient is taking placebo drug. Now, some people say that this will contribute to researcher biasness, that researchers will contribute to a biasness and they do selective treatment and selective care to selective number of patients. So this will give a birth of a new clinical trial, and they called it double-blind clinical trial. Now, in double-blind clinical trials, both the prescriber and the patient, both of them don't know. Prescriber don't know what he's prescribing to this patient, and even the patient don't know what he's taking. Only the researcher know who is the active group and who is the placebo group or the control group. The problem again comes with certain type of measurement analysis biasness. So measurement biasness contributed with the researcher, that sometimes researchers, they manipulated the data and then they give some analysis that will favors the outcome. And most probably this was reported in those projects that have been funded by pharmaceutical industries or new drug discovery units. So then in that case, we will move to triple blind clinical trials. Now, triple blind clinical trials are the trials where the prescriber don't know what he's prescribing, the patient don't know what he is taking, and a person who is doing analysis for the data, he don't know what are the groups and what are the patients what they are taking. So the researcher is not involved in any step from prescribing to even analysis. Crossover clinical trials, N of 1 clinical trials, explanatory clinical trials. Usually explanatory clinical trials are pre-phase clinical trials. They are the trials we do at the drug discovery level to identify their impact on the biological system. So this is more of exploration of drug. There are very restricted number of patients with a very strong scrutiny, and they will be evaluated against healthy patients, against the diseased patients. There are several protocols we need to follow in that. Then there are certain clinical trials who will be unicentral versus multicentral. So one hospital compared to multiple hospital studies. Parallel clinical trials, sequential clinical trials, they all depend on the aims and objectives of your study. Now, there are several parameters for your research. Either you are doing clinical trials, you are doing prospective studies, you are doing epidemiological studies, or you are doing any cross-sectional or any type of studies. First of all, you need to have a selection criteria regarding your study group. What type of patients you will take, how you are going to take. It involves sampling techniques. It involves the sample size calculation as well. Then you will be mainly focused on the exclusion criteria. Please remember one important thing here. I see several theses, I see several research projects and paper, several patients, several students of mine. They write there several exclusion criteria. I'm not going to take this patient. I'm not going to take this type of patient and this and this and this. This is very dangerous. Please discuss with your research supervisor, okay, your mentor. Excluding unnecessary samples or unnecessary characters of the patients will lead to insufficient representation. Insufficient representation from a sample group. So please be very careful about exclusion criteria. Plus, there are types of studies, so you need to look into different types of studies. There are study groups and control groups. Study groups based on the disease, there's certain population. Again, further, those groups were further divided into different types of cares, different types of disease medicines you are encounter them. Sometimes people misinterpret placebo. People think that placebo is only a drug or a sugar-coated medicines. No, sometimes placebo means usual care. So placebo means that you are not doing something special. You are not doing any experimental. You are providing usual care, and now you want to do some extra care to the patient that will become your experimental or intervention. And then you want to compare both. Okay, you want to compare what's the usual care outcome and what is the outcome for the if you provide an extra care or specific services to the patients. This is a clinical trial registry. I will highly recommend all of you to please go there, search. There are several trials. Every day there are several trials conducted all across the world with different topics. You will get a pretty good idea what people are doing around the world, and you will get several research topics from there. Now, here I want to highlight one more thing. If you want to design your clinical trial, once you prepare your proposal, you need to get IRB approval, Institutional Research Board, or ethics approval. After you get your ethics approval, you need to have at least, you need to register your trial protocol to the WHO primary registry. Now, this clinical trial is one of the primary registry for the WHO. Except that there are other registries as well. So you can use any registry with the Netherlands clinical trials, BMC clinical trials. A lot of times students miss that, or young researchers miss to register their trial. Please don't conduct your trial. First, you need to register. After you get your IRB approval, you need to register your trial to the primary WHO primary clinical trial registry database. So they will evaluate your protocol and they make sure that you are not, copying or matching with other clinical trials currently recognized or conducting around the world. Now, study variables. So I know that you know about the dependent variables, you know about independent variables, you know about confounding variables, you know about surrogate variables, intermediate variables. But here I will be not more focusing about that. I want to just give you a superficial idea about dependent and independent variables. So dependent variables is something that is relative to the measurements, that is relative to exposure. You expose something. This is the outcome, like pain. Pain is the outcome. So if you give any medicine, what would be the impact on the pain? If you give anything else, what would be the impact on that? On the wound size, on the fracture level, on the internal healing, or the cancer nodule size. Okay. Then number of treatments, type of techniques, all of these are independent, are the dependent variables. Independent variables, these are very important variables. Okay, these are patient-related variables like age, sex, presence of lesions. Either there is a disease, there is a lesion, there is no lesion, the impact on the outcome, on the death or alive, and all that. Okay, so when you are designing your protocol, you really need to scrutinize what are your dependent variables, what are your independent variables. Okay, why? Because when you scrutinize them, you need to make sure that you do the measurements based on the type of variable you are selecting. Okay, so I want to give you a little explanation here, some examples here. So for example, if you are talking about age, so normally we use age as a numerical variable. We will not use as a nominal variable or any other variable. We will take the numbers, and we usually take it at the first time of visit when the patient comes. Okay, so even in this type of tables will help you to scrutinize your data. This type of tables will help you to streamline your research project with your variables, dependent and independent variables. Plus, also you can make something like this for your dependent variables. Usually we will have 1 or 2 dependent variables because your outcomes are either 1 or 2, not more than that. We have more independent variables because we have more exposures, more confounding variables and intermediate variables. Now, biasness and analysis. So there are systematic errors based on different types of errors or different types of biasness in the treatment group or in the control group. I really want to tell you here about Bergson biasness. Bergson biasness usually happen in case control studies. Case control studies means when we have cases and controls. Controls are usually healthy volunteers. So when we have cases, there is a high probability the patient with the disease has more exposure to the disease or to the risk factors. So their admittance to the hospital is, the rate of admittance to the hospital is higher as compared to the control. Okay, so this is called as Bergson biasness. So if you look into the thesis, you look into the analysis, please don't report hospitalization, rate of hospitalization in case control studies because it is contributed by Bergson biasness. Then there is an interviewer bias. So from its name, you will know that the person who is taking the interview, a lot of times they use some open-ended question and they do some constructive techniques to extract the data from the patient in the interview. So a lot of times it is possible that the interviewer, they forget to take some information from the patient, and this leads to certain type of biasness across the groups. So what we usually do to avoid this biasness, we can have a structured questionnaire that will help us to, or the researcher or to the interviewer, to remember what are the specific questions I need to work with. Then there is an information biasness, that is the measuring of exposure in case control studies, different intensity between the two different groups. So if one group is taking more clinical or more conservative environment as compared to the other group, there is a chances that the level of adherence is increased in a controlled environment as compared to the level of adherence in uncontrolled environment. Also, the level of compliance in controlled environment will be different as compared to the uncontrolled environment. Memory bias is very common when you are dealing with a patient's memory. When you ask the patient to recall something, that what they eat, what was their previous lab values, so it is a highly chance that they will give you a data that is wrong. And this will lead to overestimation of odd ratios. Odd ratios is the predictive analysis where we will estimate that if this will happen, there is how much likely chance to develop the outcome in this way. So this will overestimate the odd ratios. This will tell us that there is a highly likely chance of this thing. Observational biasness, sometimes people, they report wrong thing, they observe wrong thing, or they missed some data from the real scenario. So actually they recorded certain values that are not actually, or they are not the real values. So this observational bias, we need to usually do specific training, structured training and specific trainings to avoid this observational biasness. Publication bias is a very important bias, and we usually do this publication bias when we were doing meta-analysis or the systematic reviews, not in clinical trials. It's not relative to clinical trial methodology. Selectional bias, again, it is from its name, you will know that how you select the patient. So if you are selecting by randomization process, what type of randomization, cluster randomization, systematic randomization, or you are doing any other randomization, you are using convenient sampling, you are doing stratification. So each technique again depend what is your objectives, what are your groups, what are their characteristics. So you select certain type of methodology for sampling technique. Type 1 error, from its name, you know there are type 1 error, there are type 2 errors, and then I'm going to tell you there are also type 3 errors. As we know, type 1 errors are mainly relevant to the statistical term when there is when we are rejecting our null hypothesis, which is actually true. There is no impact, but due to statistical problems, due to statistical biasness, due to any other biasness, we are concluding the wrong results. Okay, so in this way, our study applies to type 1 error. That although we are concluding that our null hypothesis is wrong, but actually due to certain biasness and measurement errors or statistical errors, your conclusion is wrong. It's biased. Okay, that's why it leads to type 1 error. Type 2 errors is opposite of type 1. So even you are accepting the null hypothesis, but actually there is an effect. Your null hypothesis say that there is no effect of this variable on the outcome. But in actual scenario, there is an effect of this variable on the outcome. So when you are concluding something, again, because of certain biasness and measurement errors or statistical errors, or you use different techniques, you use wrong techniques, and you will anticipate any biasness during data collection, you will lead to type 2 errors. Now, type 3 errors is a different level. We know, for example, we know that linagliptin is a very good drug, diabetic drug we probably use in the diabetic patients with kidney failure. But somehow your study, your case control study is recommending sulfonylureas over DPP4, linagliptin. So this will tell me that your study responding or reporting of your study or data collection, the person who's collecting the data or reporting the data has some problem. They didn't report properly, they didn't evaluate properly, or there is some measurement biasness during the procedure. There is another error, we call them global alpha error. This error is usually happen when you do multiple comparisons. Multiple comparison means that I have 5 variables, independent variables, and I have 5 dependent variables, and I am doing multiple comparison without scrutinizing them at the univariate analysis. I'm directly going to multivariate analysis. Now, in this way, your results and your predictive impact on the outcome will become biased. You will get the positive predictive that this variable has a 10 time or 100% effect on the outcome, but this effect is wrong predictive value. I write this article long back, I think in 2011 or 2009, and I usually ask all my students that, and I'm going to ask these questions to all of you as well. Please ask this question to yourself. Is the statistical significance is a relevant tool for assessing clinical significance? Now, a lot of times I see in my research projects that there are several variables who are statistically significant, and they are telling me that this variable has is having a correlation factor, or this one has a covariance or association with the outcome. But actually, this outcome has no clinical significance. And a lot of time, my statistical analysis tell me that there is no gender differences, there is no impact of age, or there is no impact of minor or mild kidney failure on the treatment outcome. But eventually, when we go through with the in-depth analysis or in-depth patient review, qualitative review or subjective review, we will see that there is an impact, but statistically it is not measurable because the statistics requires to follow majority with a 5% margin of error. So normally I suggest all my students that when you are designing your research project, please design your research project in both manner, that you will have one objective that should be quantitative in nature, and then you should have another objective that will look into the subjective or the qualitative nature of the clinical signs and symptoms. So in this way, you will have a 360 view of your patient treatment plan. Either your treatment is successful or your analysis is appropriate, giving you an appropriate conclusion or not. So when you look into statistics, you will have descriptive type of statistics, inferential analysis. You will have central tendencies, mean, mode, median. You will have dispersions, that is standard deviations, standard mean errors and all that. Then you will have sensitivity and specificity. Sensitivity means if your test is saying that this patient have COVID-19, then this is true positive value. So among 100 patients who have actually COVID, if you do this test with them, how many patients will come positive with your test? So for example, if you have 95 patients come positive with this test, with this specific test, it means that you have 95% specificity, sensitivity with this test. Similarly, we do certain tests to make sure that the patient is now disease free. So in tuberculosis, we do certain tests to make, like Mentox test or skin test or a chest x-ray. We do those tests to make sure the patient is now disease free, right? There is no more disease left in the body. So if we know that my patient is already disease free, and I'm now doing this test to evaluate the specificity of the test. So for example, out of 100 patients, still 5 patients come positive with this test. It means that there is a 5% chance that this test will give me a false positive result. So in this way, your specificity will be again 95%. There is a chance of error to 5%. Correlation, usually positive correlation and negative, direct and indirect correlations. We use Pearson techniques and Spaceman technique to see if my one variable is increasing, what would be the impact on the outcome. So if I'm increasing the age, what is the impact on the outcome? If I'm increasing the dose, what is the impact on the outcome? If I am increasing the length of stay, what is the impact on the nosocomial infection rate? Something like that, the impact. Then there will be univariate analysis. So initially I asked my students, because there are so many independent variables, there are around 20 to 25 variables. So I asked my students always that please first look into the covariance and associations of all these 25 variables one-to-one with the outcome. If they are associated with positive significance value, p-value, then you will include them for your multivariate analysis. If they have no covariance and association, don't include them. Okay. Then further, out of 25 variables, probably you have 5 or 6 variables that are highly or that are significant to the outcome. Now this will only tell us that they are associated with the outcome. This will not tell me how much association. This will not tell me how much reduction will reduce how much in outcome. Okay, so to do that, we will do multivariate analysis and regression analysis. That if I reduce 5% in dose, how much reduction in the death? 10% reduction, 20% reduction, 30% reduction. This should be done by using multivariate and logistic or regression analysis. Okay, so when you complete your research, you have certain checklists to follow. Please remember, all the journals, they require you to report your studies according to certain guidelines, and these are the guidelines. If you are using meta-analysis of observational studies, you need to use Moore's guideline. If you are using the meta-analysis of other observational studies and you are looking for epidemiological studies, then you need to do STROBE design, STROBE guidelines. If you are using other studies, you are evaluating other things, reporting standards, then you need to use CHEERS, Strega, and others are also available for PRISMA and other things. Please go through with your research method and make sure that you have those reporting guidelines ready with you at the proposal phase. Okay, I'm just giving you some examples here. There are certain checklists. If you want to do your clinical trials, please make sure that before you submit your clinical trials for IRB approvals, or you submit your clinical trial to any WHO primary trial registry to register your trial, make sure that you have completed all these requirements. Okay. If you missed any of these requirements, there is a highly likely chance that IRB they still can approve, because they has nothing to do with the implementation. They have more into the ethical consents of your proposal. But WHO primary health registry, your organizational, where you want to do your study, they require all these things and they require all these informations. It's very important. Now, essential services. If you want to develop your central clinical trial unit in your university, hospital, or in your institution, you need to have certain services before you step into the clinical trial unit, or you want to develop a clinical trial unit. First of all, you need to have a proper team, scientific mentorship and navigation. There must be a team members or experienced researchers who know how to conduct a clinical trial, who have been a previous experience, so they can mentor a team. They develop the procedures, and then they will tell you how to proceed. Okay. Similarly, there will be other things, including supervision, research staff, protocol development, study coordination, innovative. You will use certain softwares. You have to ask your members to go with a good clinical practice certificate. It is a free certificate. Without this certification, nobody can do a clinical trial. So if you want to do a clinical trial, I really want you to go and get your GCP certification. Okay. Then how do I know that your clinical trial is a successful unit? So it depends on the number and skill levels of clinical and basic scientists, level of outcome in terms of your publications, your audits, your research projects you are doing, how many trainings you are doing, how many research you are conducting right now, how many less reported errors, how many proper reporting systems you have. All these things come under this measurements. Again, this is a flow chart where you will see investigator training and research, administrative and coordinator support, resource allocation to startup, space needed. You need rooms, data rooms, storage rooms of data, observation rooms, therapy rooms, marketing planning in case if you need to enroll patients, a standard charge rate. So if you are doing some analysis during the research, you need to charge the laboratories. If you are paying to the patient, how much you are paying to the patient. If you are paying to the nurses or pharmacists, how much you are paying to them. So standard charge rate. Building an existing infrastructure. So if you have a hospital and you want to make a unit over there, so you should have a minimum beds, separators, rooms, nursing stations, clinical pharmacist room, and all that. I think I'm going to stop here because it's only 7 minutes left, and I want to open the floor for questions. And Hafsa, all back to you if you want to ask.
Thank you so much, sir, for this session. Actually, we designed this session according to the layout that panelists will also join the discussion, but we are facing some internet connectivity issue in the Pakistan. It's about an year that we are hearing that there is a problem in the underwater internet cable, etc. But however,
Sure.
I want to personally conclude, and I want to mention a few points. First of all, I have attended many sessions and completed courses from different universities in US as well. I want to mention this important thing that a course that was conducted a year ago by Stanford University, multiple researchers were covering that course. And this presentation is exactly equal to that whole module. Sir, you actually summarize each and everything. That even if someone wants to appear in any sort of interview or want to set up a proper, knowledge-based module, then this presentation is actually going to lead in every. So thank you so much for great piece of knowledge. You shared links as well for the registration. And here I want to mention one thing that we mostly neglect while we are studying in this area. First of all, you talked about the changing variables during the research. You talked about 25 different variables. You asked your students to work on that. So we are looking globally on this point that many people neglect this. That's why we were seeing previously about the CVS effects of even COVID vaccines as well. So I'm sure that there's something lacking there. So this point is very important, of course. Then you talked about qualitative and quantitative analysis. You know that when we were studying in pharmacy 4th year, then we were talked about to collect the surveys in quantitative analysis and quantitative data. And we were assuming that this is the all data that we need to collect, and these are the results, and according to these results, we need to conclude. But that's actually wrong. All those students who were from Pharmacology should learn from this as well. And then one important point you highlighted is that rejection of null hypothesis is not the end. That's an important thing because there could be multiple reasons for that rejection. So we should not leave that one. That's how the discoveries occur, right?
Yeah.
And then you talked about the novelty of idea. We are always chasing towards novelty, but applicability is very important. And I want to mention one important thing that when we are talking about applicability, we can consider over ethnicity and region specification. Although we are going to publish it globally, but for us, over regions, specificity is more important because we are working here. So this was actually one of very important point. Then you talked about memory biasness. While collecting patient history, most of the people neglect this point. Memory biasness occur there as well. So thank you so much for highlighting all these points and for presenting such a wonderful piece of knowledge. Thank you so much. And we are hoping to join you on another platform as well. Thank you so much for sparing your time. We are really
so that I would also come and
yes, sir. Sir Hassan. Actually, sir, I want to thank you for this session and conclude the session. But as I told you before, that we have some internet connectivity issues here. So thank you so much. And
thank you, Hafsa, for giving.
Thank you, everybody who joined this session. Allah Hafiz.
Thank you very much. Take care.